Coming up next is a case presentation by Dr. E. Ganesh, a final year postgraduate from Coimbatore Medical College. We request the dynamic.
I think Ganesh is a PG. He had a miraculous escape in his life. You are the person, no? He got injured and treated in MMC. Now let me see whether he is getting any escape from Satyamurthy and Subramania also now.
Good evening to everyone. First of all, I thank Professor Dr. Srinivasan sir and also my head of the department, Professor Dr. Boma, for giving this opportunity to present here. Dakshita, 3-year, 10-month-old girl child, firstborn child to non-consanguineous parents, resident of Arakonam, brought by parents with infirmities mother whose reliability is good. With chief complaints of puffiness of face for the past 6 days, reduced urine output for the past 5 days, swelling of legs for the past 4 days, and abdominal distension for the past 4 days.
Hello. So, what is the tetrad of nephrotic syndrome?
Nephrotic syndrome consists of massive edema, massive proteinuria, and hypoalbuminemia and hypercholesterolemia. Child is a known case of renal disease and apparently all right 6 days ago, and mother noticed swelling of face with eyelid puffiness which gradually subsided as the day progresses, and next day child complained of reduced urine output. Initially child was passing 6 to 7 times urine per day, and mother noticed only two times passed on that day with high colored urine. Complaints of swelling of legs for the past 4 days and abdominal distension which started 3 days after facial puffiness, uniform distension, gradually progressive. There is no history of cola color urine, no history of fever, painful micturition. There is no complaints of breathing difficulty, chest pain, palpitation, no complaints of yellowish discoloration of eyes, no complaints of skin and hair changes, no history of insect bite or swelling of lips.
Why do you ask for cola colored urine?
To fix the problem, whether it's a nephritic or nephrotic, cola color urine is a feature of nephritic syndrome.
Can this be can this anusaka be due to cardiovascular cause? Suppose I am saying this is due to cardiovascular cause.
First, for cardiovascular cause, usually edema start usually in the legs, gradually progress to face and abdomen, and child will be presenting with breathlessness even on first day itself. Child will have breathlessness.
The main presenting complaint in a child with cardiovascular disease is breathlessness. Usually the present of breathlessness, the reason for why they come to the hospital is mainly for breathlessness. Edema is relatively a later manifestation. Okay. Then why chest pain? Chest pain is a common manifestation in a child. What is the common cause of chest pain in a child?
It's a musculoskeletal.
That is not.
Yes.
And can this be due to hepatic cause? Or
Hepatic cause.
You go back to previous slide.
There is no complaints of yellowish discoloration of eyes. Child is a known case of renal disease, so.
Yeah, is it enough? Yellowish discoloration of eyes is it enough to rule out a hepatic cause? Because yellowish discoloration of eyes, I would like to think of an acute condition like your viral hepatitis. Okay, and generalized edema doesn't occur in acute condition. Usually, because of chronic liver disease goes for decomposition, then only the child goes for edema.
Yes.
Okay, even then the edema is mainly they come for abdominal distension, not like generalized edema. So I think you should stop. I mean, you should not have stopped with yellow discoloration of the eyes. Okay, you should have included other features of chronic liver disease also.
Loss of appetite and vomiting should also be included.
And what about the skin and hair changes?
Skin and hair changes for malnutrition as a cause of edema, and insect bite and swelling of legs for anaphylactic edema.
Again, can you think of a nutritional cause for this generalist answer? Can you think of a nutritional cause?
Mostly second born child will be affected, and abdominal distension will be prolonged.
Is it the answer? Or I mean, would you like to think in terms of a nutritional cause? The child is presented acutely.
Yes.
Okay, it was a previously normal.
Be prolonged abdominal distension in nutritional cause.
Other illnesses, child would be sick. Okay, other thing is oliguria is usually not a feature of protein malnutrition. Okay, they don't present with oliguria, right?
Yes.
Next.
There is no complaint of headache, altered sensorium, vomiting, blood vision, seizures. No complaints of paraxial nocturnal dyspnea, orthopnea. No complaints of flank pain, abdominal pain. There is no precipitating illness like cough and cold, loose stool, vomiting, localized skin swelling, pain, tenderness. No complaints of fever with rash, arthralgia. No complaints of bleeding manifestation, bony pain.
What is the importance of the fever with rash and arthralgia? Why did you include in the history?
To rule out secondary causes of nephrotic syndrome like connective tissue disorders, SLE.
SLE, what is the age group? Usually, what is the age group that is associated with nephrotic syndrome?
Usually adolescents.
Adolescents. Even SLE by itself on the presence usually it's rare below the age of 5 years. Okay, and to present with nephrotic syndrome, it's an older child or an adolescent age, not in this age group, right?
Yes. Past history, child was apparently normal till 1.5 years of age. At 1.5 years of age, child admitted at ICH for the first time with similar complaint as above and diagnosed of kidney problem, advised to take long-term medication. Child took treatment almost 3.5 months and drugs were tapered and stopped as per physician advice. Child was symptom free after 1 month of stopping drug therapy and again second episode of the same problem which was precipitated by acute diarrheal disease, and child was given treatment for 2 months and drug tapered and compliance was good during the course of treatment. Child asymptomatic 4 months after the second episode, that is first relapse, and again at third episode which was treated for 2 months, and child was not on any drugs for the past 2 months. This fourth episode.
This four episodes over a period of?
Sir, there is a gap. First and second relapse occurred within a period of 6 months, so this mostly be a frequent relapse.
I don't get it.
First episode occurred at 1.5 years of age, but first relapse or second episode occurred at 2 years 2 months, which is 8 months after the first episode. But the second and third episode occurred within 6 months, so it is considered as a frequent relapse.
So what do you mean by relapse?
Relapse is defined as urine albumin 3 plus or 4 plus on 3 consecutive early morning sample, those who attained previously remission.
Why do you take an early morning sample?
To rule out orthostatic proteinuria, which is
Fix up orthostatic.
protein.
When will you call frequent relapse?
Occurrence of two or more relapse in within 6 months or 4 or more relapse in any 12 months.
When will you call remission?
Urine albumin nil or trace on 3 consecutive urine early morning sample is considered remission.
So it should be also along with the clinical symptoms.
Remission of clinical symptoms.
So the edema subsides, urine output increases, fetal edema is everything. So associated with biochemical changes. Okay.
Yes. Antenatal history unevenful, birth history, postnatal history unevenful, developmentally normal child, immunized up to 1.5 years of age as per national immunization schedule, and no history of optional vaccinations. Diet history, child is having calorie deficit of 100 and taking adequate protein. Family history, no history of similar illness in the family and no history of renal disease in family.
1250 calories. How do you reach it? 1250 calories. How did you reach it?
Sir,
What is the method adopted?
Sir, 24-hour recall method before pre-illness normal diet.
Recommended calories?
From ICMR guidelines 1 to 3 years.
Protein.
Sorry, 4 to 6 years. Yes.
Protein recommended.
Calorie and protein, sir.
Okay, what is the formula used for the calorie requirement? What is the formula that is used for calorie requirement, for calculating calorie requirement?
First 10 kg, 100 calorie.
So that is a rough estimation.
Yes.
What is the formula called? Holiday cycle.
Holiday cycle.
Yeah, my question is not that. Yeah?
Yes,
The similar formula is used for
Fluid.
also. What is the difference? You calculate for calories and you calculate for fluids. What is the difference? Then one is when you are calculating for calories, you take the expected weight. When you are calculating for fluids, you take the present weight. Right? Then about the family history. Supposing there is a positive family history, what will come to your mind?
Positive family history.
Positive, there is one more child in the family which is having a nephrotic syndrome, particularly steroid-resistant nephrotic syndrome. What will come to your mind?
We should suspect Alport syndrome and
Alport is something.
It's a
membranoproliferative nephrotic syndrome. We should suspect.
Yeah, familial type of focal segmental glomerulosclerosis.
Yes.
We should know about this because these types of diseases are usually they are resistant to immunosuppressants and they quickly progress to end-stage engineering disease.
Yes.
Okay, so supposing there's one more child in the family with steroid-resistant nephrotic syndrome, we should be alert.
Okay.
Right.
On summarizing the history, this 3-year, 10-month-old girl child, known case of kidney disease, presented with facial puffiness, reduced urine output, abdominal distension, pedal edema with the previous 3 episodes, including 2 relapses occurring within 6 months period with no precipitating factor, with no complication, probably a nephrotic syndrome with frequent relapse. On examination, child is alert, oriented, comfortable, afebrile.
1 second. Child is comfortable with generalized edema. Okay. Child is comfortable with generalized edema. What will come to your mind?
There is no pleural effusion.
Yeah, a comfortable child with edema, with generalized edema maybe. Supposing it's a comfortable child, okay, otherwise playful, it develops edema, think of nephrotic syndrome. Supposing if it's an acutely sick child,
Other causes.
think of
Cardiac.
acutely sick child, generalized edema, think of
Cardiac causes or complication.
Think of a capillarily acutely sick child. Supposing it's a chronically sick child, edema, think of a chronic liver disease.
Yes.
Decompensating liver disease. Right?
Facial puffiness with eyelid swelling present, abdomen distended, bilateral pitting pedal edema was present, no pallor, no tick, no cyanosis, no clubbing, no generalized significant lymphadenopathy. Vital signs, pulse rate was 92 per minute, regular rhythm, normal volume, no specific character, felt equally in all palpable peripheral pulses, no radial radiofemoral delay, respiratory rate was 20 per minute, thoraco-abdominal, temperature 98 degree Fahrenheit, blood pressure was 90-60 millimeter of mercury in right upper limb in lying posture.
Supposing there is hypertension. Supposing there is hypertension in your child, what will come to your mind?
We should suspect nephritic onset nephrotic syndrome or other than minimal change nephrotic syndrome, we should suspect membranoproliferative focal segmental or secondary causes of nephrotic syndrome.
Can you get hypertension and minimal change?
Yes. 5 to 10%.
Yeah, transient hypertension can occur in minimal change nephrotic syndrome. And the second thing is when the child is on steroids. Right?
Anthropometry, weight is 16 kg against expected for 15 kg, 50th to 97th centile. Height is 1 or 2 centimeter between 50th to 97th centile. Head circumference 49 centimeter. Weight for height is 50th to 99th centile. Head to foot examination, head size normal, scalp normal, no scalp edema, face is normal, eyes normal, skin normal.
3-year-old child, should you not take midterm circumference?
Yes.
You should take
17 centimeter it was.
Why didn't you mention?
I forgot to type.
Right.
Back normal, extremities normal, skin normal. Coming to systemic examination, inspection of the abdomen. Abdomen was uniformly distended, umbilicus in mid position, inverted. All quadrants of abdomen move equally with respiration. Flanks appears to be full, and skin over the abdomen normal. No dilated veins, scars, sinuses. Hernial orifices are free, and external genitalia normal. Renal angle free. On palpation, abdomen was soft, normal warmth, non-tender, no guarding rigidity, no abdominal wall edema. Liver is not palpable, spleen is not palpable. On percussion, liver dullness felt at right fifth intercostal space in midclavicular line. Liver span was 7.5 cm, which is normal. Shifting dullness was present.
What does it indicate? Presence of shifting dullness.
Moderate ascites. Around 1000 ml of fluid is present.
What does the fluid through indicate?
Fluid through indicate massive ascites, more than 1.5 liter fluid.
Never mention that is not adult teaching, because a 1 month child is also belongs to pediatric age group, and a 12-year-old child also belongs to pediatric age group. So that is not adult presentation. That indicates the fluid is there is massive fluid under tension.
Yes.
Okay, can you get both in the same patient, both fluid through and shifting dullness?
No.
Why?
If fluid thrill is present, we cannot displace the fluid while doing shifting dullness.
There should be space, okay,
Yes.
for shifting dullness to be present. Okay, and what are the conditions when shifting dullness is not present? There is fluid, but shifting dullness is not present. What are the conditions?
Come on. Again.
Fluid is present, but
Yes,
shifting dullness is not there.
Loculated ascites,
One is a
if in
loculated fluid.
inflamed and peritoneum and collection.
Additions, presence
Additions.
of additions, like in the case of tuberculous peritonitis, right? The third thing is the fluid, fluid, massive fluid,
Yes.
right? And what is the sir was telling about minimal fluid puddle sign? It goes by a name, puddle sign.
Putting the child in
I'm not asking, sir already told about this. Puddle sign goes by a name, it has a name. It's called Lawson's sign. Okay?
Yes.
Right.
auscultation, bowels on here normally, and cardiovascular system examination. Apical impulse felt at left fifth intercostal space in midclavicular line. First and second heart sound here normally, no murmur. Respiratory system examination, bilateral air entry equally present, no added sound. Central nervous system examination, child was conscious, oriented. Higher mental function, cranial nerves, motor, sensory examination normal. On summary, there is 3-year 10-month-old male girl child, firstborn child of non-consanguineous parents, known case of nephrotic syndrome since 1.5 years of age, with three previous episodes, now presented with facial puffiness, abdominal distension, pedal edema, without precipitating illness. On examination, anasarca, generalized abdominal distension, shifting dullness, a case of nephrotic syndrome with a frequent relapse. Third relapse.
Why do you say it's frequent relapses?
Because second and third episode occurred within 6 months, it comes under frequent relapse.
Okay, what are you going to do for this child?
Any case of renal disease, first we have to do urine routine with the microscopic examination. Urine, first we have to look for gross macroscopic examination.
Whenever you present the exam, when they ask about urine examination, you say macroscopic and microscopic. Macroscopic, by macroscopic you tell us about the volume or the color.
Yes.
Okay.
Volume and color of the urine, whether we can see the frothing of the urine. Also microscopy, we can look for any asymptomatic microscopic hematuria, look for renal cast, also RBC cast to rule out nephritic.
What type of cast that you get in nephrotic syndrome?
It's a tubular cast.
Tubular cast. What type of cast?
Hyaline cast.
Hyaline cast.
Yes.
But before the proteins. What about the proteins?
We should look for protein by dipstick or biochemical test. Dipstick examination, there is 6 grading of proteinuria by dipstick, nil and 1 plus. 1 plus indicates less than 30 milligram of protein, and 1 plus 2 plus 30 to 100 milligram, and 100 to 1000 is 3 plus, and more than 1000 milligram per day is 4 plus.
When do you get false positive proteinuria? When do you get a false positive test?
When there is a contamination, also.
Contamination, yes. Then hematuria. Hematuria or pyuria or highly concentrated urine or alkaline urine, all these conditions, so you get a false positive test. Yes. So what are the other methods of testing of the proteinuria?
By biochemical test, by sulfosalicylic acid test and heat coagulation test. And
what is spot protein?
Next is spot protein creatine ratio. In nephrotic range proteinuria, spot protein creatine ratio will be more than 2, and less than 0.2 is normal. And other 24-hour urine protein quantification to confirm the diagnosis of nephrotic syndrome, which is usually more than 40 milligram per meter square per hour, or more than 50 milligram per kg per day, or more than 3.5 gram in 24 hours.
So, will you ask the mother to collect 24-hour urine?
Ask the child to void in the early morning sample and collect from 8 a.m. to 8 a.m. next.
What first day morning 8 a.m. what will you do?
Ask the child to void first voided urine.
Okay, then you will take the wound or you will discard?
Discard.
So first day you will discard the urine, 8 o'clock means, and then
collect from subsequent voiding, and up to next 24 hours we have to collect.
Next day 8 o'clock what will you do?
And measure the volume, and
at 8 o'clock next day you ask the child to pass urine and you have to collect into the sample.
Yes.
Measure the total volume. How will you do heat coagulation test?
Heat coagulation, in a test tube we have to take up to half to 3/4 of the urine sample and heat the upper part of the coagulum, and the coagulum. Yes.
Upper part of the test tube.
Upper part of the test tube, and coagulum will be formed in the lower part, and we have to.
Why do you hit the upper part? Why not the lower part?
Because the coagulum will be formed in the lower part.
No, it's not like that. Lower part is taken as a control. You will get the coagulum in the upper part only, not in the lower part.
Yes. Next, to assess the renal function test, blood urea nitrogen, serum creatinine, and serum electrolyte, and complete hemogram to assess to look for occult infection and associated anemia, and confirm the diagnosis. We have to look for serum albumin and lipid profile to look for hypercholesterolemia.
Why do you get hyperlipidemia?
Because the serum protein is low massive proteinuria leading to hyperalbuminemia. Liver synthesize increased synthesis of lipoproteins.
Then? That is one mechanism.
And decreased lipoprotein lipase.
Loss of
Lipoprotein lipase in the urine.
Right. What is the rule of 2 in nephrotic syndrome? What is the rule of 2 in nephrotic syndrome? I think less than more than 2 grams of proteinuria, less than 2 grams of albumin, and 220 milligrams of cholesterol.
Yes.
Right? Then.
And if we suspect a secondary cause of nephrotic syndrome, we have to do serum ANA complement level.
Yes, what's your comment on ANA? What is your comment on ANA? Is it better to go for ANA or something else?
It's a clear-cut case of minimal change.
ANA you do for what?
Double standard DNA we have to go for specific diagnosis of SLE.
Right.
And rule out occult infection. For the first time we have diagnosed, we should rule out tuberculosis infection, do MAN2 and chest X-ray.
Before mentioning ANA, you should mention these things first, because you would like to rule out, and before starting the child on steroids, you would like to exclude the infections. So although tuberculosis has to be excluded, MAN2 test, X-ray chest, urine culture.
Yes. USG abdomen we have.
Suspected focus. Any suspected focus of sepsis should be ruled out. Okay, these are the common things that you do in every case of nephrotic syndrome. So these things should be mentioned first before you go into special investigations, right?
And coming to treatment of
when you call nephrotic range of proteinuria?
Nephrotic range proteinuria is urine dipstick 3+ or 4+ with urine protein excretion more than 50 mg per kg per day, or more than 40 mg per meter square per hour, or more than 3.5 gram in 24 hours.
Not 3.5. What you said is correct. 40 mg per meter square
Per
hour or 50 mg per kg per day, and then spot urine
Spot
ratio
more than 2.
What are the classification of nephrotic syndrome? How will you classify?
So nephrotic syndrome based on age at onset classified as congenital nephrotic syndrome between birth to 3 months, and infantile nephrotic syndrome 3 to 12 months, and childhood onset nephrotic syndrome 1 to 6 years mostly. And primary or idiopathic nephrotic syndrome is the most common. Under primary category, minimal change nephrotic syndrome is most common, followed by focal segmental glomerulosclerosis, membranoproliferative and membranous nephropathy, and crescentric and IgA nephropathy.
The investigation mentioned what is what are the indications for renal biopsy?
So we should go for renal biopsy in atypical age presentation, less than 1 year, and more than 8 years recommended for renal biopsy. And also, if child having hypertension, renal insufficiency, or hypocomplementemia, and gross hematuria or persistent microscopic hematuria, we should go for renal biopsy.
What are the indications for genetic testing? Genetic testing.
If age at onset less than 1 year and suspected congenital nephrotic syndrome, if although the previous sibling also having family history of nephrotic syndrome, the previous sibling we should suspect. Mostly, if suspecting syndromic cause of nephrotic syndrome, also congenital Finnish type and Danish stress syndrome we should go for.
Second thing is the positive family history.
Yes.
Okay, and any child which is not responding to your regular course of treatment, like not responding to immunosuppressants.
Yes.
Right.
So what are the genetic mutations in nephrotic syndrome?
Nephrin mutation and podocin and Wim's tumor mutation. Also, the basement membrane proteins also having mutation, alpha-actinin, laminin mutations also implicated.
What are the syndromes associated with nephrotic syndrome?
Some nail patella syndrome, Galloway-Mallet syndrome,
Pearson syndrome,
Pearson
syndrome.
is.
How will you treat first episode of nephrotic syndrome?
Adequate treatment of first episode nephrotic syndrome is very important. Before starting steroids, we should rule out occult infection, and if there is edema, we should control edema by salt restriction indicated less than 1.5 gram of sodium per day. If the child having hyponatremia, and fluid restriction also if signs of fluidor and massive edema, and prednisolones.
What about the diet, bro? What type of diet would you like to go for? Would you like to go for a high protein diet or a normal protein or low protein?
High quality protein diet recommended.
High quality protein diet.
Yes.
That is the now quantity. What about the quantity? Normal quantity or higher quantity?
Normal quantity.
Normal quantity.
Yes.
Why? Because the child is losing protein in the urine. Why don't you go for a higher, increased quantity?
It will increase the renal injury,
Hyperfiltration and glomerular.
hyperfiltration injury.
So what you like to go for is a normal protein with normal protein of high biological value.
Yes.
What do you mean by high biological value?
Biological value around 100.
So what is the definition of high biological value? Biological value.
Based on net protein ratio, net protein utilization and
That is the percentage of nitrogen that is retained.
yes.
Examples on the high quality protein is egg and milk.
Yes.
Okay. What about the fat?
Fat intake less than 30% of total calorie requirement and less than 10% should be saturated fat. Saturated fat should be
So can a child take per day?
cholesterol normal amount.
That's 300 milligrams. Okay. And how much an egg yolk contain? How much of cholesterol does an egg yolk contain?
6 gram.
6 grams of protein.
Fat also 6 gram.
Fat is also 6 grams. No, it's 200 milligrams.
Yes.
Okay. Right. Then
And prednisolone is a drug of choice and treatment divided into initial phase and maintenance phase. And initial phase at least take for 6 weeks 2 milligram per kg of prednisolone, and at the end of 6 weeks child should have attained remission, and after 6 weeks we can switch over to 1.5 milligram per kg per day of prednisolone, and according to KDIGO guidelines for first episode managed 8 weeks to 5 months to prevent to decrease the chance of further relapses. At least 12 weeks of treatment should be total duration of treatment.
right. What do you do for relapses?
Relapse, for infrequent relapse we have to start to 2 milligram per kg per day of prednisolone, and stop the drug when child attaining remission, that is 3 consecutive days nil or trace urine albumin attained. We have to stop daily regimen and followed by alternate drug 1.5 milligram per kg for 4 weeks, and we have to stop abruptly the treatment for infrequent relapse. For frequent relapse and steroid dependent nephrotic syndrome according to Indian Society of Pediatric Nephrology guidelines, and we have to continue the alternate steroids for 9 to 18 months at the dose of 0.5 to 0.7 milligram per kg of prednisolone.
What are the indications for steroid sparing agents?
If child having signs of steroid toxicity or not steroid toxicity in the form of hypertension, cataract, growth failure, or not attaining remission with 0.5 to 0.7 milligram per kg of steroids, that is reach the prednisolone threshold, we have to start steroid sparing drugs. Steroid sparing.
What are the other drugs other than steroid prednisolone?
So, steroid sparing drugs most commonly used levomazole in the dose of 2 to 2.5 milligram per kg on alternate day. We have to continue for 1 to 2 years, and other drugs oral cyclophosphamide also can be given.
And what are the precautions that you take? When you are giving cyclophosphamide, what are the precautions that you take?
Cyclophosphamide cause bone marrow suppression, and we have to monitor CBC, also causes sterility, alopecia, and hemorrhagic cystitis.
These are the side effects, but the precautions?
We have to look for cumulative dosage.
Yes, what is the
Maximum cumulative dosage 150 milligram per kg. 168.
168 milligram.
If more than 250 milligram per kg of dose attained, go for azoospermia and gonadal toxicity.
You keep a watch on the leukocyte count. If the leukocyte count on the drops below 4,000,
We have to stop the
we have to stop the treatment, and usually it's better not to repeat the course.
up to 3 months only we have to give oral cyclophosphamide. Other drugs can be given mycophenolate mofetil and calcineurin inhibitor, mainly reserved for steroid resistant nephrotic syndrome.
What is the toxicity of calcineurin inhibitors?
Calcineurin inhibitor main toxicity hypertension, hyperglycemia, and causes hirsutism, gum.
What is the most important toxicity? Calcineurin inhibitors, what is the most important toxicity?
Gum hypertrophy.
Most important toxicity.
Nephrotoxicity.
Nephrotoxicity, both acute and chronic nephrotoxicity can occur. So what are the
Also,
how do you monitor the treatment? When you put the child on calcineurin inhibitors, how do you monitor the treatment?
we have to do renal function test, periodic renal function test, and
Renal function tests are to be done, and when creatinine value goes 25% above the baseline, we should go worried. Then keep a watch on the lipid levels, and the renal biopsy 2 years after starting the treatment. Okay, all these things have to be considered. And what about the edema? What is the role of furosemide in the edema?
edema management, we have to assess a child whether the child was fluid depleted or fluid overloaded. In case of fluid overload, volume depleted with edema.
My question is, when you are giving furosemide, there is a child with nephrotic syndrome with
Judicious use of.
What are the precautions that you will take, or what complications can you expect when you give furosemide to a child with severe edema?
Child may go for shock, renal dysfunction, and worsening of the underlying problem.
Okay, what is alternative?
Alternate spironolactone can be given at the dose.
Okay, other than diuretics.
And albumin can be given 25% albumin, and under coverage of steroids, diuretics can be given.
Diuretics can be given. What are the complications that you can expect with albumin infusion?
Even with albumin infusion, the child may go for volume overload, pulmonary edema, and breathing difficulty.
Why it happens? Why it happens? Why the child goes for pulmonary edema to volume?
Restoration of intravascular volume.
It increases.
Increase.
So when albumin is given, it increases the oncotic pressure. So it absorbs the
fluids from intestine.
What is rituximab?
It's an anti-CD20 monoclonal antibody. It can be given 1 to 2 doses if not responding to, in case of steroid-resistant nephrotic syndrome, not responding to calcineurin inhibitors, we can try 1 to 2 doses of rituximab.
What about the role of vaccines? Suppose a child comes to you with nephrotic syndrome.
Yes. And vaccination, live vaccine cannot be given during daily steroid therapy, that is 2 mg per kg per day or more than 20 mg per day steroid therapy.
Live vaccines. Live vaccines. Can you give when the child is on full dose of steroids?
No sir, cannot be given. And only after stopping 4 weeks we can give live vaccine. Killed vaccine can be given, and live vaccine can be given during alternate day steroid regimen.
Less than 0.5 mg.
Yes.
So, or after 6 weeks, after stopping the steroids, even in the low dose also you are not supposed to give. After stopping steroid only.
Okay.
In case of less than 2 year, conjugated pneumococcal vaccine, 3 doses to be given.
And annual flu
5
vaccine.
years, 1 dose of conjugated pneumococcal vaccine plus 23 valent pneumococcal vaccine 8 weeks later. After 5 years, 1 dose of 23 valent pneumococcal vaccine.
Yes.
And varicella vaccine can be given after stopping steroids, 8 weeks after stopping steroids.
Okay.
What are the complications?
Complication, infection, most common complication, child already immunocompromised with
Why do they get frequent infections?
there is a loss of complement factor C2, C4 and alternate complement pathway factors like factor B and factor H lost in urine, also porphyrin factor lost in urine. So child more prone for infection. Also the collection of fluid will favor the precipitate the infection.
Okay, what type of infection do you get?
It's most common pneumococcal infection, most common, also gram-negative infection. Spontaneous bacterial peritonitis we should suspect whenever the child present with abdominal pain, and also we should look for other focus of infection, pneumonia.
Any other complications?
renal vein thrombosis and cortical vein thrombosis also common because the coagulation factor lost in urine, and also hemoconcentration favoring platelet aggregation and thrombosis.
So why do you get hypocalcemia?
Although the calcium binding protein lost in urine, calcium level will be normal only. Vitamin D binding.
There is a lack of vitamin D, and there will be lack of vitamin D, and also there will be gut edema. So there will be impaired absorption of calcium. Not only that, there will be hypoalbuminemia. Okay. Then the other thing is, for each gram of albumin loss, what will be the loss of calcium? For each gram of albumin that is lost, 0.8 milligram of calcium that is lost. So the one more thing is your this furosemide, which causes hypercalciuria. Okay, all these things put together, the child goes in for hypercalcemia. Okay, so you have to go for supplementation, calcium supplementation, right?